Hi YouTube, my name is Michael Berenger. I'm a medical doctor and a full professor of sports medicine and exercise physiology at Goethe University Frankfurt, Germany. Today I want to talk with you about a very important topic in sports medicine, and that is muscle injuries. Why is that so important? Because muscle injuries are incredibly common in sports. In elite football, just to give you an idea about the scale, muscle injuries account for nearly a third of all injuries, so that is about 15 per team per season, adding up to over 220 days of absence each season. So that's quite a lot. And it's not just professionals, so you don't need to be a professional soccer player to injure your muscle. Of course, you can just go to the gym or play tennis. And when the muscle is injured, you might ask yourself, okay, how severe is that? How long will it take to heal? And what should I do? To answer those questions sufficiently, we need to look at the science behind muscle injuries. So let's do this. So first of all, what is a muscle injury? The funny thing is, despite how common they are, muscle injuries are still surprisingly complex to manage. One big problem what we have is the inconsistency in terminology. What does that mean? That means that often people use different terms for the same thing or the same word for different things. And that creates confusion even among medical professionals. To bring clarity to that topic, several classification systems were developed. One of them is the Munich consensus statement. And this statement distinguishes between functional disorders, type 1 and type 2, and structural injuries, type 3 and 4. What is meant by functional disorders here? This includes fatigue or neuromuscular issues, and I think this is very important to see that injuries are already functional disorders. You don't have to have a muscle tear or something. Functional disorders already are part of muscle injuries. And then there you have the classic structural injuries involving partial or complete fiber tears or muscle tears. 7 years later, the British athletic system has been published, and this focuses more on MRI-based grades about the severity from 0 to 4 and location markers. So A means myofascial, B is muscular tendinous, and C is intratendinous. And in the same year, there is the Histoarchitectural classification that has been published, and this one goes even deeper, describing injuries by affected tissues. So tendon, aponeurosis or fascia. And why is that important? Because those tissues heal differently. So if the tendon is involved, or the aponeurosis, the healing is slower when compared to more superficial fascial injuries. At our lab, we view functional and structural injuries as some type of continuum. So fatigue, for example, increases the intracellular calcium and may predispose to more serious injuries. And this is supported by data from soccer. So hamstring injuries increase at the end of each half when fatigue peaks. So then the question is, how do muscle injuries occur? And then what happens next? First of all, muscle injuries typically occur when the force exceeds the muscle tendon unit's capacity. And this capacity may be reduced due to fatigue. Eccentric contractions, or the muscle lengthens under tension, are especially risky. And sprinting is a classic example. So in the late swing phase, the hamstrings are stretched and contracted at the same time. And this creates a perfect storm for injury. The most frequent injured site is the myotendinous junction, or abbreviated MTJ. This is where the muscle meets the tendon, if you want to say that. Other injuries can affect the aponeurosis, intramuscular parts of the tendon or the fascia, and each of these has different healing properties. Therefore, it's so important to know exactly what we're talking about. Once injured, the muscle goes through three biological phases. First is the destruction. So damaged fibers die depending on the severity of the fiber damage, and then inflammation starts. Of course, not the entire fiber needs to die. Damage can also induce inflammation. Then comes the second part, the repair phase. Satellite cells may be activated and start rebuilding. And then the third part is the new fibers mature, integrate, and restore the function. But recovery isn't equal. So tendon injuries heal slower and carry a higher risk of fibrosis or recurrence. So that leads us to the question, in case when you have your muscle injured, what should you do? Well, the classic advice was RICE: rest, ice, compression, and elevation. Well, but recent science has updated that view, because rest, yes, that's okay, but briefly. A few days of protection help to avoid re-rupture and stabilizes the scar tissue. Ice, yes, that can help early on with pain and inflammation, but prolonged, that may delay the healing, especially if this is overused. And furthermore, there is no high level of evidence that ice actually speeds up recovery. The same thing holds true for compression and elevation. Yes, it can help to reduce the swelling, but the evidence is limited. So what is the best practice advice here? Short rest is good. Limited use of ice is okay. Early gentle loading and then movement done right promotes the regeneration and minimizes the scarring tissue. Well, when you do that, after that, you want to know exactly what happened, what is damaged, and the diagnosis starts with the history. How and when did it happen? What was the mechanism? Was it during sprinting or overstretching? Some of the muscle injuries can be palpated, or you can use functional testing to get a better idea of the muscle injury. Imaging refines all this. Ultrasound can be used. That's great for dynamic assessment and the early evaluation. MRI is best for deeper or higher grade injuries and tissue-specific damage. And there's a more newer technique, the ultrasound elastography. This is very interesting because it gives us information about the muscle stiffness. And this stiffness is changed in those early phases of muscle injury or the functional injuries that we just talked about. The goal is to identify what tissue is involved and how severe the damage is. And that brings us to the next part, to the rehabilitation. There it is important to balance the loading and protection. So first of all, rehab must respect the biology. So too much rest leads to a weakness, and too much stress risks the re-injury rate. A typical plan could be that you say for the first 3 days, relative rest, gentle isometric contractions. Thereafter, from day 3 to 7, light pain-free loading is okay. From week 2 on, you can add slowly eccentric and functional training. And the final phase is then sport-specific drills and high-speed work. But the tissue type matters. So myofascial injuries recover quickly and tolerate early motion, while tendon and aponeurotic injuries need longer and therefore a more gradual loading. So the return to play or return to competition should be based on function and not time. So the key criteria should be, for example, strength symmetry. You can compare one side with the other. You can have a look on the movement control. And importantly, no pain during sport-specific tasks. If this is still painful, then this athlete or yourself, you're not ready for the return to play or the return to competition. This is an important part. So let's wrap that up. Muscle injuries are complex to manage and therefore classification matters. Healing follows biology. We have inflammation, repair, and remodeling. And then ice. Yes, it's helpful, but not essential. Rehab must be tailored to the injury type and phase. And then it's important to have an accurate diagnosis, a functional progression, and that leads finally to better outcomes. Thanks for watching. If you found this helpful, check out our Lab Talk series for more deep dives into those lab methods that we use, and of course for injury prevention. And as always, subscribe for more updates. See you soon. Bye-bye.